Good afternoon, everyone. Senator Mary Washington, honored to be the Senate Chair of the Joint Committee on Children, Youth, and Families, along with Delegate Ariana Kelly. We're calling our Tuesday, December 6th meeting to order. Today, we are having a conversation and some briefings on a very important topic. But before we get into it, I again want to just thank all of the members who have served over the last 2 years, especially the last 3 years during this period of COVID, a pandemic, recovery. Just this committee has been very, very important, lifting up the concerns and challenges of our children, of our youth, and of our families. I think we've done some really important work. And to that, we have members that are not continuing or who are retiring from their years of service. And so I was going to just ask Delegate Kelly if she would make a comment, those members, as all of our Senate members are returning.
Well, aren't you fortunate over on the Senate side? We will be losing Delegate Susan Krebs, who has been an extraordinary member of this committee, as well as my committee, the Health and Government Operations Committee. And I really want to thank her for her many contributions to both committees, and particularly her diligence, her attention to detail, her concern for childcare. And I don't know, Delegate Krebs, if you wanted to add anything.
No, but thank you. It's been a great committee to serve on. It really affects many, many things that go on in our counties and our jurisdictions. And I think it's a very powerful committee, and I thank you all for your attention to it, to all the issues that have come up, especially during COVID. So thank you all. I've enjoyed it.
And Delegate Krebs, I've had the honor of serving with you in the House, and then have always appreciate your attention to detail, as you said, and just your commitment to the cause and the issues and speaking up. And saying things that need to be said.
And I'm sure you'll keep it all up. Thank you.
Yes, we will.
Senator Washington,
yes.
Can I just add that we are losing one of our great senators also?
I see she just signed on.
Oh, she just signed on. I'm sorry.
She signed on. Welcome, Senator Eckert.
So I guess I was in denial. Thank you, Senator King.
Yeah, thank you very much.
Patty Eckert. I have a special connection with you. One, of course, we served together in a house, but also you're a nurse and my mother's a nurse. Participation in our women's caucus, participation whenever there are issues affecting our most vulnerable people. You stood up for those issues no matter, whose idea it was, beyond party, always seeking cooperation and collaboration. Your participation in this committee has been, of course, instrumental. And yeah, I guess I was I was ignoring the fact that you'll be retiring, and but we look forward to knowing that you'll continue to do great things. Would any other members want to say anything, to our great senator from the shore? Yes, Senator King.
Well, I would, because I've been together on the Budget and Tax Committee with Addie, and we've done a lot of different committees and meetings together, and we could always count on her to stand up on any of the health issues. She was never intimidated by all the men in the room. She would stand up and speak her piece, and she has done a lot for the state of Maryland, and she will be greatly missed, I think, by all of us, but especially me.
Thank you.
I'd like to chime in if I can. I actually know both outgoing members and had the pleasure of serving in the House of Delegates, and but in particular to Senator Eckert, who served on the subcommittee for Health and Human Services during my time there with Budget and Tax. But even during my time in the House, look, each member brings their own personality and their own energy, but Senator Eckert, even as a delegate, brought a heart for those who would not always be who you would be expecting her to fight but she's always fought for the most vulnerable and those who might, without her, not have had a voice. And so I just appreciate her contributions, her sincerity, her homework, and her tenacity, because sometimes she would bring up things and I'd go, yeah, that's not gonna necessarily, and she just fought and worked with the committee and was willing to amend and adjust until we could get to compromises that worked for both sides. So thank you, my friend, for your service, and look forward to continuing to work together in other areas. Thank you for letting us do this, Madam Chairs.
Oh, absolutely. Senator Hedelman.
Thank you. Thank you, Madam Chairs. I also just wanted to put my 2 cents in. I've worked with both Delegate Krebs and Senator Eckert just a short time in the Senate, but really appreciate her friendship and warmth, and you will be sorely missed. Really sorely missed. And Delegate Krebs, philosophically, we come often at 180 degrees, but you have been incredibly helpful in the House. One particular piece of legislation, as I recall, and I just really appreciate your candor and your commitment on behalf of your constituents as well. So thank you both for your service very much.
You're here on the Krebs part too. Yeah.
I think
Like
this,
I know they're all
Delegate
the men in the room, but one of the men in the room wants to weigh in.
Go ahead,
Um,
Delegate Ebersol.
Okay, nothing struck fear into my heart more than seeing Delegate Krebs asked to speak when I was defending a bill on the floor. She's too darn smart. But beyond that, Addie Eckert, I'm going to say this and I'm going to explain it. You were my first, okay? The first time I was ever assigned to be chair of a conference committee, you were my conference committee on the other side on a bill that wasn't as important as it was that it was the first time. I don't know if you remember, it was on taxes on backpacks. But thank you for handling me gently that time.
and I would be remiss if I didn't mention, even though it's not service on this committee, but on the vaccine distribution in our work group to ensure that the shore and our rural communities receive their vaccinations, and then very specifically your work there, we know quite literally save lives over time. So again, thank you all for that, and also for our speakers today. Thank you. I appreciate your cooperation and patience, allowing us to lift up the service of our members that are not returning in January. And so we are going to get a briefing again on the.
I see something now. Something changed to mute.
Someone needs to mute.
Okay.
Automatic. There we go. So I'll handle just the first, the state of youth behavioral health, and then we'll transition to Delegate Kelly. She'll handle the second, third, and then we'll close with we'll have our summary of enacted legislation and some closing slogan remarks. There's no business that we need to take care of other than to hear and be brief. So with that, yes.
Madam Chair, I just want to say that I need to scoot out. I have a pensions committee at 2:00, so I'm sorry about that. And thank you all. It's been a pleasure to work with everybody, and I think we will cross paths soon in the future. So God bless and thank you all.
I have no doubt. So today we're hearing from Margot Quinlan, the Director of Youth and Older Policy, adult policy at the Mental Health Association. So Ann Geddes, Director of Public Policy for the Maryland Coalition of Families, and Lauren Grimes, Assistant Director of Community Health. Because each of these topics are somewhat different, if the committee, after each presentation, we will have a few questions directly rather than waiting until the very end. Okay, well, thank you.
Great, thank you, Chair Washington, Chair Kelly, for inviting us to speak. And we have some slides. There we go. And we'll try to keep this short. We sort of put this together. This is a platform from our coalition, and so it covers a lot of topics that all kind of go together pretty succinctly. And so, I think we're happy to sort of run through these individually and then just take questions, but whatever feels best for the group. And so, I'm just going to jump into it and want to be conscious of time because there's a lot of data that I want to lift up, but then also some specific policy recommendations that we would propose and love to talk about or share more information about either today or, in follow-up materials. So again, my name is Margot Quinlan with the Mental Health Association of Maryland. And if we want to go to the next slide. So we chair the Maryland Children's Behavioral Health Coalition, which is made up of, and I won't read through these. I think this is included in your packets, these slides, but we have a lot of provider organizations, advocacy groups, child serving agencies, and folks that are just coming, some of the hospital systems just coming together across the state to talk about the need for youth mental health and substance use treatment options. Next slide. And so, again, I'm not going to read through all of this, but I want to just talk about some of the data and the urgency of the real crisis that we're in around youth mental health, which has just been exacerbated at a really alarming rate over the last few years with the pandemic. And really in Maryland, youth have been hit the hardest with the pandemic. And so data shows that, youth under 17 make up the highest number of people going to the emergency department for suicide attempts, a really high increase of almost 40% over those years of a sort of 2019 moving into the pandemic. The number of youth who've completed suicide, 18 to 25, has increased by 80% in 2020 to 2021, which is, just a huge number. And again, really alarming. Opioid overdose deaths have increased by 30%. And then there's really, as with everything, we see really, a lot of disparities along lines of race and other identities. And so for Black youth in Maryland schools, over 50% have reported feeling significantly sadder or more hopeless in 2021, which is almost 20% higher than the statewide average. So really a disparate impact there. And for LGBTQ youth as well, over 75% presented with significant symptoms of depression. And 1 in 2 transgender or non-binary youth in Maryland schools have reported seriously considering suicide at some point in their lives. So again, these impacts are falling, sort of disproportionately affecting different communities. Next slide. And then just talking about, and this is where I kind of want to shift our conversation, just the need and how are we meeting the needs of our young people here in the state, right? And we're seeing, there was unmet need before the pandemic. There's an increased unmet need today. So, almost half of Maryland youth from 12 to 17 years old with depressive symptoms did not receive any mental health care last year. Our community behavioral health providers are reporting really long wait times for child therapy. And then, folks have probably seen some of the reporting in the Washington Post and the Baltimore Banner. Some of these publications are reporting about our hospital overstay crisis, and we have youth that are waiting in hospital emergency departments for weeks and weeks and weeks, while mental health conditions deteriorate and symptoms worsen, and they're just waiting for care. And it is beyond the point of crisis. And we have some youth who've lost their lives while waiting for care. And so if we want to go to the next slide, again, we just feel the need here is extremely urgent, as I know, all of you on this committee also share. So this is a lot for a slide, but just to really highlight quickly the sort of impact on young people. So on the left, it shows that, statewide, we've seen an increase, of the total number of people who are reporting to hospital emergency departments, with suicide attempts or self-harm at 35%. But then on the right, or the sort of top row, shows that, that is mostly falling onto our young people. And so again, youth from, under age 17, in that last year that we have the data for, it's a 46% increase that are showing up at the hospital emergency department. So if we want to go to the next slide. So again, just, this really alarming rise in need for care and some concerning statistics. This is just a quote we pulled from the Washington Post article that came out just 2 months ago. And I'm not going to read this whole thing, but I do want to highlight this part in the middle where and I'm going to read this sentence. This is in 2010, just 1% of children 12 and younger with mental health problems stayed in the ER longer than a day. By 2020, more than 10% were getting stuck more than a day and sometimes weeks. And again, I would encourage folks to read that article for some pretty harrowing stories that were shared from families in there. Next slide. So again, this just shows, and I just really want to make sure we're always sort of raising this up, the disparate impacts. And So there was a report that came out in 2020 from the Maryland Juvenile Justice Reform Council. They had done some listening sessions across the state and really identified a lack of mental health and substance use resources as a contributing factor in the disparate criminalization of Black and Brown youth. And this chart shows from the Behavioral Health Administration that Black youth are disproportionately entering the behavioral health system at the back end and with a higher level of need, which just shows this racial disparity of access to care and to preventative services, which is preventable. We can address this with some policy change. Next slide. So what do we do about this? And this is where I kind of want to shift to the forward thinking. Some of the solutions and proposals that we would put forward, and then after that, maybe open up for questions or conversation. And so this is our youth crisis and suicide prevention platform put together by our coalition and sort of based on some of the trends and stats that we're seeing as far as what we're prioritizing right now. So this first piece, promoting equity with youth-centered service delivery systems. There was a report that was just released by the Governor's Office for Crime Control, Youth and Victim Services. I hope I'm getting that's like the right title for it, but it really underscored the sort of efficacy and the need of having youth-centered co-design in the delivery of behavioral health systems. And so looking at, a lot of states are doing this, some countries around the world are doing this, really bringing young people to the table and developing the programs, the systems, the services that they're receiving, which can help reduce stigma, increase participation, and just bring young people into these services. Because a lot of times, they're mostly, designed by people like us, people who are adults, and are often removed from what's making the services feel accessible or hospitable. And so we would really urge the General Assembly and the state agencies to just look at these models and explore some pilot programs, which is what was suggested in that report, to just start bringing youth into the process and the design process in a meaningful way. Next slide. So on this piece about disparities and just underscore the disparity for LGBTQ youth. And again, I think I mentioned that, for transgender and non-binary students in Maryland schools, 1 out of 2 report having considered suicide in the last year. And so there's, efforts, that have been led by folks on this call or in this, committee. And in the legislature, I think there's a lot of momentum for expanding Maryland Medicaid to cover gender-affirming care for trans youth through the Trans Health Equity Act. And this is a piece of, legislation and policy that has the data here shows that youth access to hormone therapy alone can reduce depression by 73%, suicide attempts by 84%. I mean, it's a significant, it's a pretty small effort that could really have a pretty enormous impact on reducing some of these mental health outcomes. So we would strongly support moving those policies forward. In the next slide. And then youth executive function programming. So these are programs that are can be done in the classroom that really can help reduce the effects of ACEs or adverse childhood experiences, can close the achievement gap, and really benefits all students across all Maryland schools. And so we've been in a lot of conversations with the Consortium for Coordinated Community Supports, which is sort of spun out of the Blueprint for Maryland's Future, the Kirwan Commission, and just talking about how do we really implement these proven interventions to help support students' learning, their cognitive, social, and emotional functioning, and would really urge, the adoption of this model across the entire state. And so happy to talk more about that. And then next slide. And this takes us into the sort of system of care and these gaps. And we were talking about the sort of gaps in service delivery and access to care. And I would want to, if I could, pass it over to Anne to talk a little bit about this in the next piece.
Right, good afternoon. So wraparound is the gold standard for treating children with most intensive mental health needs. It is an evidence-based practice. It is a model of intensive care coordination with a range of auxiliary services, following wraparound principles that's been shown to produce the best results, again, for kids with those more intensive mental health needs. In wraparound, you have a team that consists of everybody who touches that youth, family members, relatives, a teacher, a therapist, maybe a DSS worker, whoever, a DJS worker, whoever touches that kid, developing plans of care that are youth and family driven and builds on the families and the youth strengths. We used to have a high fidelity wraparound in Maryland prior to 2015. From 2010 to 2015, wraparound was serving about 350 to 400 kids a year in Maryland. Since 2015, they have a BHA revamped the program, and whereas it used to be funded with state general funds, now it's a fee-for-service model instead of, and it's being managed by various care coordinating organizations. We don't have high fidelity, and we have very few kids who are being served. Compared to that 350, 400 we've had in the last 10 years or 7 years, about 4 kids a year to 53 kids a year was the max. The last few years, it's been 11, 34, and 28. So very few kids are getting the service, and those who are not getting it with high fidelity to the model. So the outcomes have not been that great. And this is, again, this is the gold standard for treating kids with the most intensive needs. There are 2 services that are considered best practices for treating kids with significant mental health needs. Wraparound is one, and the second, if you want to go to the next slide, is mobile response and stabilization services. MRSS model of serving kids is different than crisis services for adults. Again, it's an evidence-based practice. It has been shown to significantly reduce emergency department use, inpatient hospitalizations, and out-of-home placements. The components is there's one number to call. Response teams come out for all calls, regardless of if they think it's not very serious. The crisis is defined by the caregiver of the youth. There's follow-up services, 72 hours follow-up in the home, and then stabilization services up to 8 weeks. Then most importantly, there's connections to community care. Again, you need those community resources there, such as wraparound, to connect kids to care. We've got, we can look to other states that are implementing these 2 practices, wraparound and MRSS, with successful outcomes. Vermont, Connecticut, Massachusetts, New Jersey, Oklahoma are seeing, have both of these interventions and are seeing really good results. So BHA started to roll out MRSS in Maryland. They're kind of trying to, but so far we have 2 small pilots. One in Southern Maryland released an RFP. There were no responses. The other in Western Maryland has had trouble even getting an RFP out. And those are very small, two counties in Southern Maryland and just Garrett County in Western Maryland. So we need to see that more widespread implementation of this system with fidelity to the model. So if we want to help the kids with most intensive needs, these are the 2 things we really need to focus on. You want to turn it over to Lauren?
Good afternoon, Chairs Washington and Chair Kelly. I apologize, I'm a little froggy today, but I did really want to be here. This issue is critical to discuss, not only the issue of our Maryland's children's mental health, but the issue of the Medicaid care continuum that is suffering from a lack of many of the services that are required to make sure that our kids are able to access services when they need. So again, my name is Lauren Grimes. I'm here on behalf of the Community Behavioral Health Association of Maryland. We represent 108 organizations that provide the full continuum of mental health and substance use disorder services. Our members serve the majority of the almost 300,000 children and adults who receive services in the public behavioral health system. So Ms. Geddes and Ms. Quinlan have painted an accurately bleak picture for you of the state of Maryland children's mental health. There are 2 key pieces of info that I'd like to add to the conversation. One helps us understand the complexity of the care continuum problem, which is deeper than the pandemic and broader than not enough beds. and the other helps us understand the solutions to a distorted care continuum for kids. So a little more than a decade ago, Maryland was pioneering some of the most effective treatment models in the nation. We were laying the groundwork for a shift in treating even high need kids in their communities and schools rather than institutional settings. Next slide, please. Maryland took the initial steps. It cut the number of beds available in residential treatment centers, as well as in residential group homes for foster children. The goal was to redirect this money toward in-home support and outpatient resources in the community. The problem is the expansion of community resources for children and their families never materialized. We did not build out the specialty services used by other states to meet the needs of intermediate to high acuity children. And our utilization of costly psychiatric inpatient services at almost double the national average reflected the result. Next slide, please. This was all before the pandemic. Preliminary national data shows that throughout the PHE, the rate of mental health services for children under the age of 19 declined, and it has not rebounded. Next slide, please. Maryland data confirms this. So between FY19 and FY22, there was a 13% reduction in overall use of Medicaid mental health services by children under the age of 18. That's alongside a 22% growth in Medicaid enrollment generally. So think about that decline. Next slide, please. So today we're facing the results of an abandoned treatment paradigm shift, worsened by the pandemic and worsened by the workforce crisis. The results include a treatment desert for kids with intensive needs, long waits for services, antiquated reimbursement models, which limit the ability to flexibly meet patient needs. And most alarmingly, as Margot pointed out earlier, there was a 46% increase in emergency department visits for child suicide attempts over the course of 2020 to 2021. The hopeful news is this. There are care models that can help right-size the children's continuum. Ms. Geddes discussed the importance of high-fidelity wraparound services delivered to children with especially acute needs. The complementary model, one that can keep kids from needing CME-level care and has been shown to drastically reduce hospitalizations and emergency room visits, is the CCBHC model. 23 other states across the country have implemented this model with exceptional outcomes. And Maryland's 5 pilot sites are also showing promising results. As you can see on the slide, CCBHCs offer same-day service, 24-hour crisis response, the capacity to build out specialty evidence-based practices, and most importantly, a cost-based reimbursement structure that allows agencies to deliver services where the client needs them and in closer collaboration with schools and other child-serving agencies. That means that they can be reimbursed for going to a school or working with law enforcement if a kid gets into trouble. They are not confined to the 4 walls of a clinic. The other thing is they deliver care across the lifespan. So not only can children access mental health, addiction, and primary care services under this one entity, but their parents can access them as well. This is a critical point because we know that parental substance use is the leading cause of children being placed outside the home. And being placed outside the home is traumatic and often triggers severe mental health and behavioral health challenges. So what are we asking you to do? We'd ask for your support for legislation requiring MDH to apply for a state plan amendment or a waiver to implement CCBHCs. This is critical so that we don't risk the loss of Maryland's currently 5 grant-funded CCBHCs. Some of these grants end as early as next year in 2023, and the loss of momentum in honing those models to their specific communities would not only be a loss for those served by them, but it would leave Maryland again behind the 8 ball in children's mental health rather than pioneering innovative care like we once did. I appreciate you letting me speak, and I'm happy to take any questions that you might have as well.
There it is. Thank you. Thank you so much for that, colleagues. Senator Hebbleman, you have a question that you had posted in the chat. Do you want to?
Sure. Well, two questions. One was, how does one access the MRSS services? And then also, sorry, I will go on camera. I was interested in the last presentation, you mentioned the CB, I don't know, remember the acronym, but the 5 programs that are currently funded. Can you tell us where they are and what they are? Thank you.
And I'll let you address the MRS stuff first. Yeah, go ahead.
I'll start out with the mobile response, the MRSS services system. There's one phone number to call. That's the idea, single point of access. In other states, they're integrating that now with 988. And like I said, anybody who wants help gets help. The calls aren't triaged. If a family wants someone to come out, someone comes out by calling that one number.
Do you know if there's an effort afoot to integrate that into our 988 service? Does anyone know?
Well, we don't really have it yet.
Not up.
Yeah, we don't have it up and running. We're working. We got the 988 up and running, but we don't have the MRSS up and running.
Ah, okay. I guess I didn't. Okay, thank you. And the second part?
Yeah, Senator Hedelman, I don't have the names and counties off the top of my head. Arundel Lodge is in Anne Arundel County. I know Volunteers of America runs a multi-county program. Cornerstone is in Montgomery County. And Lower Shore Clinic, I believe, serves the couple of counties in the Lower Shore. I can get these to you after the meeting, though.
Great. Thank you. Senator Eckert.
Thank you very much. And ladies, thank you for the presentation of that. That's why we're seeing so many more folks at younger ages hospitalized in our state psych facilities coming in from jails. But my question was, this has been part of the systems reform initiative, isn't that correct? Working with the department and with the Behavioral Health Advisory Committee? Anne or Lauren?
With the Behavioral Health Advisory Council?
Yeah, haven't you all been working with the department with the systems reform initiative on this as well?
So the only thing that I've been working on is there's a crisis systems work group that's been working on rolling out crisis system services that has focused mostly on adults. We haven't really, we've been talking about the Crisis Now model, which is the model for adults. We need to be talking about the MRSS model, which is the model for kids.
Great. Thanks so much. Appreciate your effort. It's very important.
Is there more to that, Senator Eckert, or that you had with that question? Or
I mean, we've been pushing this for quite some time, but I just didn't know if they had access to information that we didn't have.
Got it. Okay, thank you. Okay.
And I think that was the answer on that, because a number of groups, whether it's the Governor's Suicide Commission or the Behavioral Health or the Lieutenant Governor's Commission on Behavioral Health and Addiction, we've certainly heard all of these concerns over the past number of years. But
Senator Eckhart, if I might add to Ms. Getty's response, I think we have been working on many of the home and community-based services and the absence of many of the critical services on the continuum for a number of years, and looking for solutions to building those out. I believe specific to CCBHCs, there was a demonstration grant that was open, I believe, this month that ends on the 19th, and the Department of Health decided not to go after that. That is why we're hoping there will be some movement on either a state plan amendment legislation or some sort of waiver that would urge the department to build in the CCBHC model.
Thank you.
Thank you. Thank you. Delegate Krebs.
Thank you. On one of the slides, there was something noted about Optum. I want to know what the role of Optum is, and are they the provider? And if they are, what is their sense of what the shortcomings are? What's their response?
Delegate Krebs, that is an excellent question. I will not ever deign to speak for Optum and what they think of the continuum of care at all. I will say on that slide, you're referring specifically to the fact that that slide referenced data pre-2019, or it might have been 2019 specifically. That is the last data that the Department of Health was able to submit to SAMHSA, because once Optum took over, one can only surmise that their data is not reliable enough to turn over. And that slide was calling attention to that.
And they're required to do that by their contract?
I do believe so. Before I confirm that 100%, let me check and I will circle
It
back.
might be worth it for those that are continuing on to follow up with that and see if that's another part of their contract that is not sufficiently working. I'm looking at Delegate Kelly.
Well noted, Delegate Krebs, and this is why we're going to miss you. I appreciate it.
Thank you.
Delegate Solomon.
Thank you, Madam Chair. First of all, it's good to see you all. Margot, it's good to see you as well. I had two questions. One, just sort of more generally, I am fully in support of the more we can integrate this into the school building, the better. So I guess I'm just curious, have you all had any conversations with the State Department of Education? Do we need to push them a little bit more? I had some conversations with the previous superintendent during their budget hearings over the course of a few years, and I always felt like I was not getting a whole lot. And so just curious with the new superintendent and, you know, the emphasis that they've placed on wraparound support services, whether you're finding a more welcome environment or whether we need to maybe facilitate more conversations in that space.
I mean, I think I'd say, you know, we've been sort of really monitoring and trying to engage in the work that's being done through the blueprint legislation that passed a few years ago, right? And so those dollars with the consortium, which is sort of the body that's then, you know, working with MSDE to help figure out the behavioral health components of that funding, you know, that money is really just now about to start hitting the ground. And so we've been in, you know, those meetings, providing testimony, working with the consortium members as much as possible, just to help try to sort of lift up the best practices and the models that, you know, are recognized to really support youth and families. I haven't spoken to the superintendent. I don't know if others, you know, have or like have a different relationship there, but we've really been looking at that body as sort of the mechanism, you know, because there's so much funding and year after year funding tied to that. And so it just feels like a really important opportunity for us to be trying to move the needle on some of these. But I don't know if, you know, Anne or Lauren have other conversations that they've been in or other pieces to this.
No conversations with the superintendent.
Yeah.
Well, would love to have a follow-up and explore that more. And then the second question I had is a little bit more tangential, and we'll follow up with you all individually. But one of the bills that we're exploring putting in next session is a bill to carry. California just did it, and the United Kingdom had done it, called the Universal Design Code for technology companies with young people and kids under the age of 18. And it's really about designing technology with young people in mind, not only their privacy, but their mental health. And so obviously, you know, social media has had, I think demonstrably a huge impact on young people's mental health. So I'd like to follow up with you. It's the kind of stuff, you know, simple things like getting YouTube to turn off their autoplay, or, you know, meaning that TikTok does not allow, you know, anonymous interactions with people under the age of 18. And it's way more than that. And California's been a real great leader on it. But just wanted to throw that out there, and I'll follow up individually with you all, but would love to engage in some conversations on that work too.
That sounds great. Thanks, Delegate.
Thank you.
And Delegate, I think that's important. I think so much of the discourse around what's happening with our youth keeps being centered around you know, COVID recovery and isolation, and that there are other inputs, there are other things that are happening in the world and in technology and all of that are also exacerbating or contributing to, you know, to that. And so yeah, so thanks for raising that up. It'll be good for us to look at that. That is Senator Benson, and then Delegate Kelly. Senator Benson.
I want to kind of follow up on the last question that was asked. What are we doing in the way? I always am very supportive of wraparound services, very supportive. But what are we doing in the way of looking at the colleges and universities in the way of looking at their curriculum so that they can become more astute and privy to what they need to know when it comes to issues of mental health when it comes to our children. But also, more importantly, are we doing anything in our school system right now with teachers and with our principals? Are we bringing it from the state level down to our counties so that we can become a little more aware of what needs to be done in the way of training the teachers and the principals and the supervisors and the superintendents? Have we gone to that extent? That's the question I want to ask.
I mean, I can say the things that come to mind. So to the first part of your question, Senator, with the, our colleges and universities, I know, there's a lot of conversations about the behavioral health workforce. There's a workforce shortage in behavioral health care, just like, across the board, right? In all types of care, this is a conversation that just keeps happening. And there have been a lot of efforts, really a lot spearheaded by the legislature to pass, bills that would help diversify the behavioral health workforce through, education in our colleges and universities and bring more people into that. But there's, I think, a lot that, still needs to be done there. Absolutely. And for the, training teachers and principals in the K-12 setting, again, is certainly open if there's other avenues that I think, we as sort of the advocates and providers should be looking, but have really sort of been zeroing in on the blueprint legislation as this opportunity, because there's money in there for the technical assistance. There's money in there that can be used for this youth executive function programming that would train teachers. It doesn't necessarily mean we're paying to bring in other staff to every school, because there is money for that, right, with these community school coordinators and some of the other pieces that are in that funding. But there are programs out there that would train our teachers, the people who are in the classroom, who have the immediate relationship with the kids, to do those executive function programs, to help provide that support for our kids. And so we think that those are really good, sort of cost-effective and evidence-based models to support young people. So we're absolutely lifting that up and hoping that that'll be adopted and taken seriously and move forward.
Thank you.
Delegate Chairwoman.
Thank you so much, Senator Washington. My question, I think it's something that both Lauren and Ann sort of referenced, but I want to kind of draw this idea out a little bit. One of the things we're looking at as we have this new administration coming in is the idea, and this I'm speaking to an idea that I know is close to Senator Augustine's heart, the idea of a blueprint for behavioral health. And I wanted to know from you all, as we're looking at that, how do we specifically need to look at youth differently? How are their needs different? How are the programs different? If we're not proactive about this, might the specific and unique needs of youth be lost in that conversation? How can we make sure that doesn't happen?
I think that's a great question. And I think it's really important. Like the example I gave with crisis services, the model that the state is adopting right now for crisis services, the Crisis Now model, that is for adults. The anticipation is that 85% of the calls will be triaged and teams won't need to be sent out to help. Therefore, crisis, when somebody's a threat to self or others, or there's a risk of harm. For children and families, a crisis could be that the child is refusing to go to school, right? And the family can't get them to go to school. And the family needs somebody to come out. It may not rise to the level of crisis like you would think for adults, but it's a crisis for that child and family. So they're different needs. There are different considerations. One of the things with wraparound model is you have the child is it maybe involved, it certainly is involved with the school, right? So they may have a therapist, but they've also got teachers. They may have somebody at school who's working with them. You get all the team members together who is working with this family, who are working with this child, get them together to develop one plans of care instead of an IEP in school and a plan that the therapist has done and a requirements by DJS, and that you're really holistically looking at the child and all the systems they're operating in. So I think there are a few really important ways. And of course you have the family, right? The family is a critical part of the child's success. So you need to be looking at the family a lot more. Not that it's not important for adults, but it's a different kind of role that the family has with children. Those are some.
No, thank you. Do you have something to add, Lauren?
Yeah, if I might, that would be great. I would just add to what Anne is saying, which I completely agree with. CCBHCs are required to serve kids. And again, I want to come back to the importance of their families being able to be served within the same framework. The convenience of that for families that are struggling with multiple issues across physical and mental health domains is really, really critical. The other thing I would fold in to this conversation about the blueprint is the sense of urgency for children. And I think Margot did a great great job of reviewing that in the beginning. We have kids stuck in hospitals still for weeks and months, declining rapidly. And we have 8 to 10 years of this system not intervening into children's lives when they started to exhibit symptoms that could have been addressed by lower level care, and we're not. And so now we have bottleneck issues across the care continuum where kids cannot step down from RTC level care because there is nowhere for them to go, and they cannot step up into RTC level care because there are not enough slots. So we have to go back to the drawing board of serving children when they present with needs at the earliest possible time with the appropriate level of care, or else we will end up with a top-heavy utilization of the continuum as we see right now. Too many kids in hospitals, too many kids in inpatient. We have to write that continuum for the long term, but we also have to, in the immediate term, address the fact that we have children stuck in levels of care that are not appropriate for them.
Thank you. That's a really helpful answer. I appreciate it.
Okay, any other questions or comments on this topic? Okay, all right, I'll pass it on to you, Delegate.
Wonderful. Thank you so much. So I guess that is the end of our discussion on the state of youth behavioral health, and really thank you to all of our panelists. I could tell the members were captivated by your presentations, and we all share your concerns. So thank you for your time and energy and the work that you all do in our state. Moving on to a briefing on the Maryland Commission for Women report, At the Heart of the Pandemic, Maryland Women and the COVID-19 Crisis. We have Tawanda Bailey and Reverend Tamara Wilson here from the Commission for Women. And I think, do you guys have slides with you? It looks like we do have a screen being shared. So who would like to go first? Ms. Bailey?
Yes. Thank you for, I'm sorry. Thank you for your interest in the Maryland Commission for Women's report, At the Heart of the Pandemic, Maryland Women and the COVID-19 Crisis. My name is Tawanda Bailey, and I am the chair of the Maryland Commission for Women. Joining me today is Reverend Tamara Wilson, who chaired the research committee for this project. Next slide. As you may know, the Maryland Commission for Women is a 25-member commission or an advisory board whose commissioners are appointed by the governor with the advice and consent of the state. The commission was first established by the executive order in 1965 as the governor's commission on the status of women. In 1971, the commission was reestablished as the Maryland Commission for Women and was permanently set in law. An office of the State Department of Human Services, next slide. The commission is charged by its enabling legislation with the duty to study the status of women in our state, direct attention to the critical problems confronting women, recommend methods of overcoming discrimination, and recognize the women's accomplishments and contributions, and lastly, provide informed advice to the executive and legislative branches of government on the issues concerning the women of our state. Next slide. In 2016, the Maryland Commission for Women launched the first phase of a 3-part research initiative with the Voices of Maryland listening tour. Traveling more than 3,000 miles across the state over a 2-year period to conduct 19 public forums, asking the women of our state to talk to us about their most pressing concerns. And in addition, a survey that was available in 4 languages, gathering further information for women who may not have been able to attend these in-person forums. In their own words, The Voices of Maryland Women was published in August of 2018. It identified the top 5 issues presented by more than 1,400 women who participated in the listening tour and survey. The top 5 concerns were domestic violence and sexual assault, paid time off for parental and medical leave, drug abuse and addiction, too few women in leadership positions, and affordable quality childcare. Next slide, please. To further examine the areas of concern, the Commission undertook phase 2 of the Status of Women Initiative, extracting and compiling the most current information available about Maryland women from statistics published by a range of federal and state agencies, as well as private research and policy firms. Data collected is presented in the Maryland Women, a Status Report, which was released June 10th of 2021. The project highlighted many disparities, including a gender-based wage gap persists and especially significant for women of color. In fact, the average Black woman will have to work age 79 to earn what the average white man earns by age 60. And the average Hispanic woman would have to work to age 108 to catch up what the average white man has earned by age 60. This is partly true because 60% of all minimum wage earners in Maryland are female, and because women still tend to be clustered into just a few occupational categories. And while only 4% of Maryland couple families in Maryland live in poverty, a staggering 23% of single female-headed households with children have incomes below the poverty level. Healthcare costs represent a huge and for many unsustainable percent of working mothers' income. This is not due to the wages paid to the children workers, but in fact, the average childcare worker earns less than $12.50 an hour. So even as the research for Maryland Women, a Status Report, was being conducted, beginning in March of 2020 and continuing well into 2021, the state, the nation, and the world experienced an unprecedented challenge of the COVID-19 pandemic. Next slide, please. Much has been written nationally about the pandemic unbalanced impact on women, especially working women with dependent children. It was findings like these that led the Maryland Commission Women to launch phase 3 of the SWIM research project in June of 2021. Tamara?
Yes, good afternoon. Next slide, please. So I'm Tamara Wilson, the chair of the research committee. The third and final phase of the research examined how Maryland women specifically have been affected by the pandemic and sought to understand the challenges they continue to face as society attempted to recover. Next slide, please. At the heart of the pandemic, Maryland Women and the COVID-19 crisis was published on April 4th of this year. The report presented findings from a two-pronged research project that was conducted in 2021. The first of which was an online survey that was available in 5 languages: English, Spanish, Chinese, Korean, and French. We partnered with the County Commission for Women around the state, who encouraged women in their communities to participate in the study. The survey was launched on August the 4th of 2021 and closed on October the 15th. A total of 4,595 women responded to the survey, with residents from every one of the 24 major jurisdictions in Maryland participating. Next slide, please. The research also included 6 focus groups conducted virtually in September and October. 3 of these groups were general in nature. The 3 remaining groups concentrated on a specific area of impact, mothers with children, young children, women, business owners, and essential workers. Next slide. The data presented in our report summarize what the women responding to our survey and participating in our virtual focus groups told us. Information gleaned from national reports also shed light on other significant issues, including the particularly severe impact on the pandemic on women of color. It is important to understand that all the problems uncovered in the study, as well as those reported in other studies that showed a heightened impact on women of color, were problems before the onset of COVID-19. However, the pandemic exacerbated these problems and in some cases brought women and their families closer to their breaking point. Next slide. Respondents identified serious problems and concerns that impact women of all backgrounds. Women delayed routine health care. 43% of respondents reported putting off medical appointments, and several told of serious, extremely serious consequences as a result. Women experienced considerable depression and anxiety during the pandemic. 65% of respondents reported more frequent or greater anxiety. 45% reported feeling more depressed or depressed more often. 48% reported feeling more lonely or more isolated. Next slide, please. Women more often than their spouses lost jobs and had their hours reduced, or found that they had to quit their jobs because of family or other needs. Women experienced substantial changes or challenges with childcare and balancing work with their children's needs. As I close, I'd like to share just a few of the experiences reported by participants of our study and focus groups. These are their words. My husband died of COVID, and I was not able to visit him for 3 months. One person said, I found a lump in my left breast in February of 2020. I scheduled a mammogram in March, and then everything shut down. I had to wait almost 4 months to get my mammogram. And then, by then, I had 3 aggressive cancerous tumors. I think the hardest part of this past year was watching my teenage son suffer and decline. Went from the top of his class to failing. Another person said, I was forced to work around the clock as a teacher to convert my curriculum for virtual learning. My husband is also a teacher, and our 3-year-old was left on her own with our 9-year-old too often. I quit my job so I could help my grandchildren so their parents could work. And this last one, next slide, please. This one was especially heartbreaking. So many women, despite the insane challenges of the last 16 months, have found a way to make it work. They sacrificed their health and well-being, their careers, their resources, etc., to care for others and find a way to keep their families afloat. My larger concern at this point is what comes next. What are we going to do to ensure women can get back on their feet and not put themselves, their careers, and their mental health, well-being on the back burner? I'll turn it back over to Tawanda.
Thank you, Tamara. So that comment really sums up why we titled this report At the Heart of the Pandemic, Maryland Women and the COVID-19 Crisis. Tamara had just shared with you the highlights of the report. The full report is available on the MCW's website at www.marylandwomen.org. One thing is clear, many of these problems, childcare expenses, lack of leave, especially paid leave, let's see what else, and especially those in low-paying occupations, lack of flexibility for many women-dominated occupations, were problems before the pandemic, but their urgency became more obvious when the pandemic hit. So in response to these findings, the commission developed a list of actions needed, both for the commission itself and for other state policymakers and legislators. Next slide, please. The pandemic has shown that paid leave for dealing with family and medical needs is essential for all employees, including first responders. And in a pandemic or any time, a woman should not have to choose between losing her job or going to work when she or her family members are ill. The pandemic made it clear that there's critical need for access to affordable, quality childcare and preschool programs. At the same time, the health and safety of our childcare workers must be considered, especially in a pandemic or other crisis. It is absolutely imperative that childcare providers earn adequate wages and benefits. The average childcare teacher in Maryland earns only about $26,000 a year. Those workers, including those in female-dominated occupations like nursing, childcare, cashiers, and clerks, should be compensated fairly for the risk they took on in order for the rest of us had access to basic necessities and health care. The pandemic changed nature of work. Training for new occupations available post-pandemic and for upskilling, especially in technical fields, should be developed and made available. Next slide, please. The pandemic made clear the inequities in access to affordable and consistent internet services, which should be available equally for all residents in every part of our state, including the rural and mountainous regions. Students and households that lack internet access, computers, or adults with experience using them were a distant advantage as virtual learning took place. We must rectify the inequities in access to and experience using technology. Schools, public and private schools, address the academic needs of students directly and develop programs to help students who were left behind catch up and engage once again in learning. Many mothers said their children experienced increased anxiety during the pandemic. Programs should be developed that help students understand and cope with psychological stresses. Programs should be developed that address the mental health needs of the women on all fronts. Workplace benefits should include and support counseling and mental health services for employees. Even if the physical and medical aspects of the pandemic were all resolved tomorrow, the experience of living with and through the pandemic will be long lasting. Next slide, please. So most of the issues identified in this report at the heart of the pandemic, Maryland women and the COVID-19 crisis, are not new issues for women. The need for flexibility in the workplace, better and more accessible, affordable childcare, and equitable access to technology and better pay for women dominated occupations existed long before COVID-19. The pandemic, however, shed a glaring light on just how significant these problems really are. These issues may have existed before the pandemic, but the time to deal with them is now. Next slide. So thank you for your attention to the report, and we look forward to working with you to address these concerns. Thank you.
Thank you so much. And thank you. It is obviously a tremendous amount of work went into this research and report. Do we have any questions from members of the committee? I don't see any hands up. I will just ask a question. You did a really good job of, in the sort of the second to last slide, giving us really specific to-dos. I just wanted to ask if you had anything more specific directed to the legislature that you would like to see us working on, or maybe flesh out sort of some of the ideas that you had in bullet points for policy outcomes you would like to see as a result of this research that you're presenting us with.
I know that we definitely, one of the things we did as September, we actually put together a new committee, which is our ACT committee. And I know Ms. Tamara Wilson, who actually is chair of that committee, identified, what is the Tamara, 610? I think new initiatives that we're trying to, okay. So, I will honestly say, I want them all resolved. Tamara, your thoughts on where we are at with this, what we're doing currently?
Yes, to address some of the recommendations that were in the report, we suggested that the Commission for Women, partner in some way with legislators on how we can address paid leave for women. That's something that we've been discussing for quite some time. Childcare for working women, increasing salaries and benefits for childcare workers. I could go on, but those are the top three things that I would think that the commission would be interested in hearing how you would like to partner and move forward with.
Wonderful, thank you. And I see my co-chair, Senator Washington, has a question. Senator Washington.
First, thank you so much for lifting up the voices and the trauma that, so many women and families have gone through, and many of us here. Taking the time for that. We had a similar briefing at the beginning, if you recall, of COVID, I think a year after, and we were just starting to see some of the things that, have very clearly borne out. I would want to see added, therefore, to it, the specific behavioral health recommendations. I noticed that was not a bullet, that it is talking about the children, but also, the burden that women are feeling, its impact on health. And so we talk about the social determinants of health. Clearly, these have an impact with health. But yes, so each one of those, we need to talk during the legislative session with the commission, I think. I think we need to get right on this. So thank you so much. It just really touched me. I could feel it. Thank you for reminding us. The folks that have really brought us through this are women and families. Thank you.
Thank you. Trying to think, I think even with, with Governor-elect Moore, I think one of the things that I know he really tried to push for was also proposing universal pre-K. It's one of the programs that they were looking to really strong to try to bring into fruition as well.
But yeah, making sure, if you're not on the transition committees in this topic, please get to somebody who's on. I know we have some members that are on the transition committee, but this is definitely an area, the economic impact, the sociological impact, the psychological impact of COVID specifically on women as a group, I think is really important to lift out. And often we don't, as you noted, we don't call attention to ourselves in that way. So I do think you doing it for us would be really important. So just wanted to say thank you.
Thank you. I don't see any more hands up, just double checking. Wonderful. Well, thank you all so much for this presentation. And you may want to listen to the next section because our wonderful staffer, Ann Wagner, has prepared a summary of enacted legislation related to children, youth, and families between 2019 and 2022. So we're going to do that, and I'm sure she'll be discussing the progress we've made on paid leave in that space. So thank you, and let's turn it over to Ann. Thank you.
Great, thank you, Chair Kelly and Chair Washington. Here, I'm just gonna set up the PowerPoint on this. Okay, great. And yes, normally this presentation is only the prior year, but I know for this year we wanted to look at the bills over the whole last term. So I will go as quickly as I can through the bills we've highlighted here that relate to the Joint Committee's work and the issues you've been following over the past few interims. The first set of bills relate to long-term care issues and aging issues. So the first bill, chapters 308 and 309 of 2019, authorized the Department of Aging to make grants to nonprofits and area agencies on aging to expand and establish aging in place programs to help seniors live in their own homes or communities. Chapter 24 of 21 expanded these grants so that they could be used for senior villages. And this bill also mandated $100,000 for aging in place program grants each year, with at least 20% of these funds supporting senior villages. Chapter 414 of 2019 relates to Medicaid's home and community-based waiver services. Those are services that assist seniors and disabled individuals to stay in their homes or communities rather than living in a nursing facility or other institutional level care. And so this bill prohibits MDH from denying access to a waiver program due to lack of funding if the individual applying meets certain requirements, which are listed on the slide. Next up, Chapter 789 of 2021 relates to visitation policies in nursing homes. This came up quite a few times during the COVID-19 pandemic. And this bill requires MDH to develop guidelines for restricting visitation to reduce the spread of disease during a catastrophic health emergency. Chapters 485 and 486 of 2021 require the Maryland Department of Health to develop and publish materials to assist Maryland residents with long-term care family planning that are in line with recommendations that the Task Force on Long-Term Care Education and Planning included in its final report. Chapter 738 of 2022 specifically relates to Medicaid's Community Options Waiver Program and requires MDH to plan for and apply for federal approval for waiver participation of at least 7,500 individuals. So this would be increasing its current cap. And this bill also expands outreach by requiring the department to send applications to 600 individuals on the wait list each month. Chapter 464 of 2022 requires MDH to develop plans to reduce the wait lists and registries for its home and community-based services waivers by 50%. And it also asks or requires MDH to develop a plan to conduct eligibility determinations for individuals on the autism waiver registry and to serve at least 50% of eligible individuals for that waiver over the next few years. So then next up are bills related to childcare in Maryland. Chapters 595 and 596 of 2019 accelerated a mandated appropriation that required MSD to raise the provider reimbursement rates under the Child Care Scholarship Program so that the rates needed to be at least the 60th percentile of the most recent market rate survey in fiscal 2021. I'll just add here that since then, MSD has used federal stimulus funding to increase the reimbursement rates under this program further. So now they're at the 70th percentile of the market rate. Chapters 243 and 244 of 2021 relate to child care teacher qualifications, and the bills require that regulations establish probationary employment qualifications for individuals applying for the first time to be a child care teacher in a center serving preschool children or children at least 3 years old. And chapters 437, 438 of 2021 established the Growing Family Childcare Opportunities Pilot Program under MSDE to provide grants to local pilot programs, establishing and supporting family childcare providers. It also required the governor to appropriate $450,000 for this program in fiscal 2023 and 2024. Chapters 206 and 207 of 2022 require MSD to distribute childcare stabilization grants to providers that have faced financial hardship or suffered an operational burden during the COVID-19 pandemic. Childcare stabilization grants were originally supported with federal stimulus funds. Then in fiscal 22, the budget included $50 million in state funds. And in fiscal 23, the budget included $3.2 million in state funds for stabilization grants. Chapters 498 and 499 of 2022 establish a therapeutic childcare grant program. This is for specialized childcare and early education providers. And this bill also requires annual appropriations of $3.7 million from fiscal 2023 to fiscal 2025. Chapters 525 and 526 of 2022 made a couple changes to the Child Care Scholarship Program, including establishing a presumptive eligibility program so that families can begin receiving a scholarship at the time that they apply, and then requiring MSD and the Comptroller's Office to process scholarships within a certain time frame. These bills also waive copays for families that participate in certain other assistance programs and for families that are employed or enrolled in a career training program. And then Chapter 594 require that the governor appropriate $16 million for MSDE to distribute retention and hiring bonuses to childcare providers and employees that participate in the childcare scholarship program. So then moving on to bills related to child welfare and human services. This first bills are chapters 77 and 78 of 2019. They expand the kinship care program so that individuals who meet certain requirements, like having maintained regular contact with the child or the child's family, can be a kinship caregiver. And then chapters 635 and 636 of 2019 established a process for counties to apply for matching state funds to provide additional supplemental food benefits to children during their breaks from school, so in the summer months and in December. Chapters 108 and 109 of 2020 authorized unaccompanied minors to consent to shelter and supportive services under certain circumstances and outlined requirements that the service providers must meet in order to serve those minors. Chapters 315 and 316 of 2021 require that DHS must report additional information regarding children and foster youth in the state child welfare system to the General Assembly, and they must also publish that additional information or some of the additional information on the department's website. Under income tax credits, it's just highlighting one bill. That's Chapter 40 of 2021. That bill created a refundable child tax credit equal to $500 for each dependent child younger than age 17 and with a disability. So this bill applied to tax years 2020 through 2022 and terminates in June 30 of next year. There were two bills related to trauma-informed care passed over this legislative term. The first is Chapter 148 of 2020, and that requires MSDE in consultation with the Department of Health and Department of Human Services to develop guidelines for schools on a trauma-informed approach. And then Chapters 722 and 723 of 2021 established a commission on trauma-informed care in DHS to coordinate a statewide initiative for trauma-responsive and trauma-informed delivery of state services. Under education, Chapters 347 and 348 required MSDE and MDH to authorize healthcare practitioners at school-based health centers to provide telehealth services. Then Chapters 605 and 606 of 2021 required that the school-based health center grant administration transfer from the State Department of Education to the Maryland Department of Health as of July 1st, 2022, so which has occurred at this point. And the Secretary of Health, in consultation with MSD and other stakeholders, is required to develop guidelines for the expansion of school-based health centers. Chapters 256 and 257 from last year expanded the definition of, from 2021, expanded the definition of homeless youth who are eligible to receive tuition waivers at public higher education institutions. It also required that higher ed institutions make the tuition waiver application available, establish an appeals process, and then designate a liaison to assist homeless and foster students applying for these tuition waivers. Chapters 345 and 346 of 2021 require MSDE to create a model policy to support the educational and parenting goals and to improve educational outcomes for pregnant and parenting students. Then just to highlight a few more bills here, chapters 661 and 662 of 2019 increased the mandated funding level for the Maryland Prenatal and Infant Care Coordination Services Grant Program and established the Task Force on Maryland Maternal and Child Health. Chapters 494 and 495 of 2021 renamed that program to be the Maryland Prenatal and Infant Care Grant Program, and it expanded the fund's purpose to support federally qualified health centers and other providers of prenatal care. And then it further increased the required funding levels to start at 1.1 million in fiscal 23 and then increase to 3.1 million in fiscal 25. Chapter 48 of 2022 established the Family and Medical Leave Insurance Program and Fund to be administered by the Maryland Department of Labor. And this program will provide up to 12 weeks of benefits and paid leave to covered employees. Chapters 169 and 170 of 2022 establishes a Baltimore City Youth Data Hub to promote the health and safety of youth and to improve equitable access to programs serving youth in Baltimore City. And then finally, Chapter 494 of 2022 established the Infant and Early Childhood Mental Health Support Services Program in statute. And that program refers children and families in need of intensive mental or behavioral health services to the appropriate programs. And this bill also requires that $3 million be appropriated to the program each year, beginning in fiscal 21, I believe, or sorry, fiscal 24. So I believe that was the last bill. That concludes the presentation. I'm happy to answer any questions about these bills, but I know we also could transition to more of a roundtable format if any joint committee members want to further discuss any of these bills or highlight any of your own upcoming bills or initiatives related to the joint committee's policy areas, because I know you all had a very busy term from this long list of bills. So I'll pass it over to Chair Kelly.
Thank you so much. Thank you for that was a very comprehensive presentation, Anne, and we really, really appreciate it. I do see that Chair Washington has a question or a comment. She wanted to express her gratitude as well. Any of the members of the committee have a question for Anne about anything she presented? I don't see any more hands up. I would like to just commend us on a term well done. I think we made some really good progress. I think it was reflected in that very, very long list of really substantial policies that are going to improve families' lives. Any members of the committee want to have any opportunity to discuss something that they're working on for the upcoming session? I don't see anybody ready to present anything. So I think with that, Chair Washington, if you're comfortable, we'll just go to closing remarks. And I will start by just thanking, of course, the staff. And can you send the PowerPoint to Senator Croz's email, please? Yes, excellent. Thank the staff so much for their work. We didn't do that much this year because, of course, it was the last year of the 4-year term. But over the 4 years, I'm really proud of the work that this committee has done. It's been a highlight of my service in the legislature to be really able to dive in and focus on issues that impact children, youth, and families. And I know that the members of this committee share that passion, and it makes it a really nice place to be. Sometimes, you know, the needs of kids and families can get lost. And so I'm really glad we're able to highlight them specifically in this space. So I just want to thank everyone for the work they do in that space and their commitment to making this joint committee a wonderful place. And I will pass it off to my partner over here, Chair Washington, to have her closing remarks.
Yes. Thank you all. Thank you, staff. Again, the flexibility and the relentlessness you demonstrated, switching switching to online, figuring out, how we could continue to do our work. We very, very, very much appreciate it. And we have a lot of work still to do. Thank you, Ms. Bailey. Thank you, everyone who's presented today, Judith, our staff. And then I've also enjoyed chairing this committee. This work as a member. We were both members, Delegate Kelly, and then now to co-chair. So those are my remarks. I look forward to seeing everyone in January. That's it. Anybody else?
For having us, and happy holidays to each and every one of you.
Thank you. Same to you.
All right. We're adjourned.